I'm back, and Fernando, we heard a little bit about the dangerous patients being doctors. So the more dangerous patients are the doctors' wives. So I am the only thing between you and lunch. So I recognize that this is a dangerous time for me to talk, and I'm going to try to be as focused as possible. So the mission that I was assigned was to talk about dialysis access and how ultrasound can be useful in maximizing the use of arteriovenous fistulas. And so again, these are the same disclosures I showed before. There's one that I didn't mention before, and that is that for 5 years I was a U.S. government contractor. I did not work for the Internal Revenue Service. I did not work for the CIA. I worked for CMS, which is the Medicare, and I was the clinical coordinator for a public health program that was called Fistula First. And I don't know how much is known about this globally, but for many years in the United States, hemodialysis access, I think, was behind many other areas in the developed nations of the world because most dialysis was done through catheters and grafts, and there was an underutilization of arteriovenous fistulas. The Fistula First program was put together to promote autogenous fistulas, both in terms of constructing the fistulas and having them be more successful. And this was a 10-year program. It was collaborative, and it was extremely successful. The prevalent rate of arteriovenous fistulas for dialysis doubled from 30% to over 60% over the 8 years that this program was in effect. It is a very effective public health program. One of the most important things that came out of it was the importance of ultrasound at every stage in maximizing the utility and construction of arteriovenous fistulas. And that's what we'll focus on today. We'll talk about pre-procedure, intra-procedural, and after-procedure. The motivation for this, of course, is better care for patients, but better care for patients is the result of less morbidity, less mortality, and also results in less cost. And part of the rationale for these kind of a thing is shown in this slide here. I guess you can't see the mouse. I'll use this. This is data from the U.S. renal data system from 2010 showing the annual per person costs for interventions on dialysis access in the United States. And it's pretty easy to see that grafts and catheters have massively higher costs for health systems than arteriovenous fistulas. Of course, the most cost-effective dialysis is peritoneal dialysis. So the strategies to increase AV fistula prevalence involve evaluation of all patients, surgeons knowledgeable about different techniques to construct access, and then ways to maximize the identification of veins beyond simply looking at the arm, maximizing the success rate intraoperatively, and then post-procedural to deal with many of the maturation issues that hamper arteriovenous fistulas. So if we go through this step-by-step, pre-procedural, intra-procedural, and then post-procedural, I'll talk a little bit about each one and touch on these things for pre-procedural rationale, the criteria, what technique, and some variants that are important. This is a table from a very important paper that came out not recently, almost 20 years ago, from doctors in a medical center in New Jersey. Mike Silva was the first author on this. These doctors instituted a protocol of venous and arterial evaluation of the arm prior to the construction of dialysis access. These are the criteria they used for this evaluation, and they compared a group of patients before the initiation of this protocol and then afterwards. So what's included in here? Well, venous diameters, and this would be cephalic or basilic veins greater than 2.5 millimeters in diameter. And arterial evaluation, important number here, is the arterial lumen diameter greater than 2 millimeters. And I think just hold on to those numbers as we keep going, and we'll talk a little bit more. The impact of instituting this protocol was dramatic, and they had over 150 patients in both groups. This is the before group, and this is the after group. And we have fistulas, arteriovenous grafts, they called them bridging grafts, and catheters. And you can see that the proportion of grafts went down by half, the proportion of fistulas went up by 4, and catheter rate went way down. So by instituting this sort of evaluation, veins were identified, fistulas could be constructed, and the vast majority of patients could receive dialysis through an autogenous fistula. This experience is not unique to the state of New Jersey. This is another study that came out looking at the institution of a similar protocol, and I just draw your attention here. These are prosthetic grafts, and this is 4 years after the institution of an ultrasound protocol. The number of grafts went from 65% down to 11% in the last year, meaning that during this period of time, that final year, almost 90% of the access constructed by this group was done using autogenous veins because they were able to find appropriate veins to use. Technique is pretty simple. You need a relaxed patient, warm room to try to dilate the veins. It's useful to have the arm in a dependent position. Some authors say that a tourniquet is helpful. I'm not so sure. So labs use one or the other. You need to have a light touch. You need to use a ton of gel. And often you use the gel as a step-off to enable to have virtually no pressure on the vein while you're examining it. And you know you're doing it right if you can make the vein be a circle or make it round. Then you know you're getting an accurate measurement. Now there's a lot of veins in the arm, and some of them are ones we care about and others are ones we don't. There are some important variations that you need to be familiar with, and I'm just going to touch on a few of them. In the forearm, there's a couple of veins that we need to identify and distinguish. One is the cephalic vein, and the other is the median antebrachial vein. And this is a classic picture from Clementi's atlas, beautiful picture. In this particular patient, this is the forearm. Here's the hand and the elbows here. This is the cephalic vein. And the median antebrachial vein in this patient is this thing, which is quite small in this patient. In most patients, the median antebrachial vein is actually better than the cephalic vein, and I'll show you a picture of that. But that's differentiating these veins and knowing which one's which is a valuable thing. In the mid-arm, I think the median cubital vein is a very important vein. This is the vein that connects the cephalic or the median antebrachial vein with the basilic system. And the presence or absence of this vein is very important when you're thinking of constructing mid-arm fistulas between the proximal radial artery and the proximal and the upper arm veins. And then in the upper arm, the relationship of the basilic vein to the brachial vein, where does the basilic vein cross the fascia and become subfascial, and where does it actually join the brachial vein? Those are important variations you need to be aware of. This is not my arm, but here's the elbow here, the forearm is here, and I think you can see this is the median antebrachial vein, which is clearly the dominant vein in this individual, and here's the cephalic vein following this arch and then continuing in the upper arm with the median cubital vein going over here. So again, being familiar with these I think is really very valuable. This cartoon shows some of the variations in the basilic vein, and this is from a nice study looking at a lot of arms, and in about 2/3 of arms, the basilic vein will actually join the brachial vein up in the axilla, and the basilic vein itself will have a sufficient length to be a good autogenous access. More often, not more often, but often, 1/3 of the time, the vein will join the deep system somewhere in the distal third or the middle third of the upper arm. And this just shows two variants where you may have duplication of the brachial vein. Most patients have paired brachial veins, but you may also have a single brachial vein. The implication of this is that if you do use this short basilic vein and you want to have an upper arm fistula, you're going to actually be having, for the most part, a brachial vein fistula, which is okay, but you should know that you're doing that. We assess the veins using the basic criteria that was promulgated by Silva and the group in New Jersey. A diameter greater than 2.5 millimeters. Thickened wall is not good. They should be compressible. And it's useful to determine the continuity. In other words, don't just examine one spot, but follow that vein along and see how it hooks up to the other things, the deep system, and whether there's major branches. Depth is also something that's of use. So here's just some, simple pictures, transverse measurement. Here's a nice 4 millimeter vein. This is a beauty. I don't have any patients with veins this big. Here's a lovely vein, but it's quite deep. And again, this may be a suitable vein for constructing the fistula, but the surgeon needs to know that this will probably need to be transposed either at the initial procedure or later on. This is what you might see in the upper arm with the brachial artery, paired brachial veins of different sizes, and then a basilic vein here that's going to join probably the smaller of these brachial veins. And with compression, there's complete compression of all three of those veins, which is what you want to see. This is what a bad vein looks like. I don't know how many of you examine superficial veins, but you can see how thick the wall is. You can see the echogenicity of the wall. And even though it collapses, you can see how thick the wall is here. And this is a vein that's unsuitable, not just because it's small, but because the wall is bad. This kind of vein will not dilate and mature appropriately, even if it has a satisfactory diameter. The arterial evaluation is something that's quite variable. In my practice, I rarely evaluate the arteries unless I see an abnormality on physical examination. Some protocols for preoperative assessment do include a detailed evaluation of the arteries in all patients. And so I think a lot of that depends on the type of practice, what surgeons you work with, and so on. The things you'd want to know, I think most important is the diameter of the artery and its capability for remodeling. Heavy calcification may limit the ability of the artery to handle increased flow through the fistula. It's useful to know these other factors too, related to proximal stenosis and the like. Again, I rely principally on normal physical exam. If the patient has a normal physical exam, I'll examine the artery in the operating room and figure out where we want to do the proximal anastomosis. Physiologic testing is helpful in patients, diabetic patients, let's say, with calcified forearm arteries where pulses are not palpable. If you do duplex imaging, you want to see the diameter, you want to look for calcification, and I would do a relatively comprehensive exam looking for proximal stenosis if you're going to do it. Here's a radial artery in longitudinal view. We would not measure the diameter usually here, but this has an adequate diameter. The wall is not markedly abnormal. Would see a normal peripheral artery spectrum in the artery. I think if you see a low peak velocity, less than, say, 30, you may want to examine that artery more thoroughly before you use it as an access. This is a bad artery. You can see the echogenicity of the artery wall here. It's heavily calcified. This artery has a small diameter. Sometimes we use heavily calcified arteries like this if the diameter is adequate. Doing the anastomosis can be a little bit of a challenge for the surgeon sewing through the calcium. But if the diameter is adequate, they'll actually be okay. So that can be useful information. So if we shift to the next phase, so that's preoperative assessment, here intraoperative, and I don't know how many surgeons in the audience use ultrasound intraoperatively. I use it on every case. I find it's extremely useful. And talk a little bit about that and how I use it. I recognize that's not something in everybody's practice, but I think it's something you may consider adopting. So why do you do it? What's the rationale for this? Well, you want to confirm the preoperative studies. Sometimes the lab that did the pre-op study might have an unreliable result. You'd like to select the best conduit. And one of the things that's been seen consistently in my experience, but also in the literature, is that the diameter of superficial veins may change significantly with anesthesia. Even just going to the operating room and lying down with some sedation may cause the veins to dilate. And then when you throw in an axillary block in some patients or general anesthesia, the veins will often dilate. So veins that were seen on mapping that didn't look so good may turn out to be just fine with a little anesthesia, and you can find that out while you're operating. Sometimes evil people come and attack the beautiful vein that was found on mapping before you get to operate on it. And so identifying that can be very useful. We do have some people who do their own vein cannulations, and that can be a big problem. I also think marking where the vein is can help make your incisions more precise, and I think help with healing of the surgical wound. You don't need a complicated scanner to do this, and you don't need to be some big sophisticated sonographer. We've used this ancient bit of laptop equipment for over 10 years. We just replaced this last year. It has everything you need: reasonable grayscale and a duplex capability. All of the veins you're examining are very superficial, so you don't need any fancy probes and you don't have to do anything too complicated. So ease of use, I think, is probably important. If you have to sell this to the operating room, you want to get a unit that other surgeons can use so that you can share the cost for it. I think this is one of the more useful things for me. After I construct the fistula, I want to examine the flow through the fistula. So I look at the feeding artery. This is a brachial fistula, or fistula off the distal brachial artery, and this panel here at the beginning is flow through the fistula with the fistula open, and you can see that there's a large amount of diastolic forward flow through the brachial artery, peak systolic velocity 116, end diastolic 64 centimeters per second. And then if you pinch the fistula, you basically convert that brachial artery back into an artery feeding the forearm, and you see a marked drop back to a normal level for peripheral artery flow. This shows the diastolic forward flow with the fistula open exceeds the systolic flow in the high resistance bed. This kind of a finding not just shows the physiology of the fistula, but tells you this is a fistula that's going to stay patent and going to probably be useful for that patient. I think this is a wonderful check on your work. If you see this kind of thing, and again, contrast that to this. So this is with the fistula open. Yes, there's diastolic forward flow, but not so good. This generally indicates a problem with the fistula. Stenosis, anastomosis, a twist in the vein, something like that, that can be fixed and result in a functional fistula. You can also evaluate the cephalic vein or basilic vein. I think these measurements are a little less useful, but generally you'll see a high velocity flow pattern with lots of diastolic flow, indicating good function. If you see this kind of thing, which is a basilic vein in the proximal forearm with a peak velocity of 10, you have a problem. This would be someone that would have the arterial flow pattern that I showed you a minute ago. Okay, what about post-construction evaluation? This would be the third phase of access development where ultrasound can be useful. And the main thing I'm going to talk about here is maturation failure. There's really two settings where post-construction scanning might be useful. That would be looking for late lesions or maturation failure. I think the literature is pretty clear that for fistulas, there's very little role for surveillance. So there's really no indication to do routine evaluations with duplex ultrasound to make sure your fistula is okay. So we'll go through the rationale and technique and whatever we have for criteria. So is maturation a problem? Well, yes, it sure is. If you look at any of the big published series from all over the world, the failure of maturation of native fistulas runs anywhere from 20 to 30%. And this is what people are publishing. So you can imagine the results that are not being published are probably a whole lot worse. There are published results showing failure rates of certain fistulas up to 50%. This is usually in forearm cephalic vein fistulas in women. So gender, location, type may have an impact on this. But this is a big problem. So if you want to maximize the construction of successful fistulas, you have to deal with this component. Important to remind everybody, this is very basic information, but remind everybody, what do you need to have a working fistula that's going to be successful? You need to have blood flow through the fistula of around 600 milliliters per minute or more. The conduit itself, the vein diameter, should be 6 millimeters or larger, and the vein should be less than 6 milliliters deep. The diameter and the depth are important for the vein to be able to be successfully cannulated. So this is, many people call this the rule of sixes. And again, here's a lovely vein, almost 6 millimeters, but it's very deep. This vein probably can't be cannulated by the average person in a dialysis unit. What happens during the maturation? Three things. The vein dilates, the vein wall thickens, and there should be increased flow through the fistula. So again, one of the problems that I think is important to recognize is that a lot of the maturation failure happens in the early phase after access construction, and it is very important to get on it right away. This is a published report from an excellent group in the Netherlands, not that long ago, 10 years ago, looking at 80 patients having primary AV fistulas in 2005. Over a third of them were abandoned, and half of these were due to early thrombosis. So identifying fistulas that have a problem before they clot. And those that have a problem, it gives you the opportunity to intervene and make a difference. This is a graph, a survival graph from that same paper. And you can see that the primary patency, that would be patency without any revision or intervention, drops off like this. And then the secondary patency, where people do an intervention, is a little bit better. But one of the most important things to notice about this is that these curves don't diverge until about 90 days. That's 3 months of time when something could have been done to make a difference. And just to prove that, this is a different series from Tip Jennings, a vascular fellow in Oklahoma, United States. Difference between primary patency and secondary patency here, substantial in this first 90 days. So early identification of lesions gives the opportunity for intervention to prevent thrombosis and correct flow abnormalities. So I think fistulas should be looked at very carefully at 2 weeks by the surgeon or somebody who really knows what they're doing. If the fistula looks great, that's wonderful. If it doesn't look great, evaluate it further. And the way to evaluate it is with duplex ultrasound. So I ultrasound any fistula that doesn't seem to be coming along right, identify the issues, and then plan to do an intervention. I do all this myself. I recognize if it's a radiology department or whatever, you might identify it and refer to an interventional radiologist or nephrologist or back to the surgeon. But communication and coordination is key. The patients are often going to hemodialysis every other day, so making sure that the patient is able to go to the doctor, understands the importance of these interventions, that's really very important. So what sort of lesions do we see? This is a nice little summary from a group looking at 119 patients. And what are the problems? Well, we see stenoses. They can be in the artery leading into the fistula, which happens, but not all that often, at the anastomosis or just beyond the anastomosis. There's a lot of stenoses in the vein, usually at the site where the vein is mobilized. We often call that the swing segment, where the vein is moved over to where the artery is. And as you can tell from these proportions here, many patients have multiple lesions. They may have an arterial stenosis and anastomotic stenosis, some branches and other things, all in the same patient. This is another important paper that shows that these are 100 patients with maturation failure. So these are accesses that would have been abandoned and the surgeon would have started over. It turns out in this group that about 40% had an arterial anastomotic issue, about 80% had some venous stenosis, and almost 50% had branches that were diverting flow from the main channel. Each of these conditions can be treated with a high success rate. Now, I'm always suspicious when someone tells me that they have a success rate of 100%. Well, okay, let's say it's 80%. That's fine, because all of these 100 patients would have had a failed fistula. So if they salvage 80, I'm very happy with that. So identifying these lesions early, using the duplex ultrasound, and then being prepared to intervene. Okay? So what sort of evaluation should we do? It should be complete evaluation of the access. And that means you start, and I generally say at least one segment above the anastomosis. So if the anastomosis is at the wrist, you start up here at the brachial artery and follow it all the way, follow the radial artery all the way through the forearm. If it's a distal brachial arterial anastomosis, the brachial artery should be examined through the whole upper arm. Then you look at the anastomosis itself, the entire length of the conduit. There's only a distal anastomosis in grafts. I'm not really going to talk about grafts, so I'll just focus on fistulas. What aspects to the examination? I think the most important ones are the grayscale, the pulsed Doppler, and volumetric flow. Color Doppler in this situation, I think, is often confusing and not always very helpful. Artery stenoses. Generally, you can use the typical criteria we would use for a regular old artery that is not feeding a fistula, and that's a combination of the absolute peak systolic velocity and a normalized ratio, peak systolic velocity ratio across the stenosis, proximal in the stenosis. You expect to see a low resistance flow characteristic feeding the fistula, like I showed you from the intraoperative picture. High resistance indicates a problem somewhere. So this is the kind of thing you'd like to see in this is a proximal radial artery, this brachial artery here, ulnar artery going that way, and here is the radial artery. And this is the sort of flow pattern you'd like to see in a normal setting. Here we are down the radial artery, And again, tight envelope of velocities, all in a good range, lots of diastolic flow. That's extremely normal and just what you'd like to see in the inflow artery. You see something like this, and I think everyone would agree this is a stenosis. Peak velocity is over 600 centimeters per second. It's focal, there's some turbulence in that area, and the artery is visibly small. So this is a stenosis in the inflow artery. Important to recognize that, again, here's the differentiation between what you would like to see in a spectrum and what you might see in a fistula that's patent but not working very well, okay? Now, when we get to the arteriovenous anastomosis, or we look within the vein, it's really involves a lot of judgment. And the reason for this is that the flow around the anastomosis and within the vein is always turbulent. Unless you're looking at an arteriovenous graft that has a uniform diameter, veins have varying diameter. They're not always straight. The flow is often bidirectional, particularly at the anastomosis. Flow velocities are always high, and the color is a mess, which is why I think in most cases it's confusing. And it's important to put together the whole picture, what you see at the area of concern and what you see overall with the access. So this is a nice picture of a typical radiocephalic fistula. The radial artery's here, the anastomosis is here, the flow direction changes, and of course the diameter of the blood vessel changes substantially as well. The pressure gradient across this anastomosis go from arterial pressure here to almost venous pressure within a few centimeters. That sort of waterfall of flow produces tremendous shear forces and all kinds of crazy flow patterns. This is just an illustration. These are shear forces, wall shear forces in arteriovenous anastomosis. And I just want to show the configuration. And if you look at the curvature here, you look at the changes in diameter, you can see why you'd get crazy flow dynamics in here and why it can be so unpredictable. Branches, depending on where you do the fistula, the forearm fistulas is often a lot of branches. Some are tributaries, some are perforators. And it can be a little bit difficult to sort that out. You need to know the common features. This is in some ways similar to the lower extremity venous reflux studies where you need to know what's going on. Branches are pretty easy to identify. So you slide along the cephalic vein. Here's one circle, here's two, and then they separate. So that's pretty nice. And you turn the color on and they're pretty easy to see. What you really want to try to do is discriminate between discrete branches or tributaries and what I like to call a profusion of branches. When you see this kind of situation, it usually means that the main outflow vein is occluded and that this is the flow is going into a network of superficial veins that probably goes nowhere. And this may be an unsalvageable situation. So just to show some x-rays that demonstrate this is a forearm, the wrist hand is over here, the elbow is over here. The catheter here is in the median antebrachial vein, and this shows a flow into the fistula. The arteriovenous anastomosis is here, and there's diversion of flow into this relatively discrete. This is actually the cephalic vein and one of its branches. Pretty straightforward. Here's another example. The arteriovenous anastomosis here is actually here, and the outflow vein is occluded. And so the contrast passes into this network of veins all over the forearm. And so usually the sonographer can differentiate these two types of branches pretty clearly. Another thing to note, and I'm not going to talk about steel because that's another half-hour lecture, and I know you're all getting very hungry. But there's virtually always reversal of flow in the artery distal to the arteriovenous anastomosis. So steel is something we always see, or almost always see. The reversal may be part of the cardiac cycle or the entire cardiac cycle. Most steel is not symptomatic, but this is a common finding you'll see distal. And it's more prominent in the radial artery. This is the radial artery here. This is the proximal radial artery coming down to the fistula, and then we're sampling in the distal radial artery with flow coming from the hand. So within the conduit, usually in a nice graft or a well a normal appearing vein, the velocities will generally tend to decrease as you go along the fistula from the anastomosis more distally. If you see a focal increase in velocity, that often suggests a specific stenosis. If it's diffuse, it could be just due to high flow through the fistula. In other words, it's got liters of flow going through it, or perhaps a long stenosis. And assessing the flow patterns and peak velocities by themselves is difficult. Volumetric flow can be very helpful here, and we'll talk a little bit about that. So this is an arteriovenous graft. You can see the graft wall here on the grayscale. And so this is relatively proximal, peak velocity relatively high. As we go along the graft, it goes down to 258, and then as you get closer to the venous anastomosis, it goes down to 132. So this gradual decline in peak velocity through the graft is pretty typical. So native fistula, this is a nice big vein and relatively superficial. We generally will provide both these numbers, the diameter of the vein and the degree of distance from the skin surface. This is about 4 millimeters deep and should be easy to cannulate. Here's a graft. This one's tunneled probably a little too deeply. That can be a problem for cannulation even with a graft. And just to show some grayscale pictures, just for fun, this is a pseudoaneurysm deep to the graft. This is a prosthetic graft, and the grayscale, they look like that. We don't really see pseudoaneurysms with fistulas. Mostly they're seen with grafts. Color makes it look like that. This is something I thought would be useful for people to see. This is a prosthetic graft, and it's a PTFE or Gore-Tex graft. You can see the characteristic double wall here. But this is a graft that's been in use for about 5 years. And I think you can tell in most of the surface, the graft is basically gone. The needles have gone through the graft and basically destroyed the wall of the PTFE. And so distinguishing between a focal pseudoaneurysm like I showed you back here, where there's a one little hole that's leaking, from a graft that's basically falling apart, it's important information to pass along to the rest of the team. Fistulas do tend to dilate. This is related to repeated puncture and the high velocity flow and remodeling of the veins. Generally, we don't worry about that as long as the flow is good, the patient is getting good dialysis, effective clearances. If the vein diameter gets above about 2.5 centimeters, or you see thrombus within the conduit, that's probably reason to do further testing. So here's a dilated cephalic vein. One other thing I wanted to show you is that often the outflow from forearm, particularly cephalic or median antebrachial fistulas, is not into the basilic system or into the upper arm cephalic vein, but into the deep venous system. And often that occurs through the antecubital perforator vein and has a characteristic appearance. So this is patient's hand is over here. The upper arm is over here. This is the antecubital region. So cephalic vein comes up like this. It's actually occluded in the antecubital region, but the flow all goes through this perforator vein into the deep venous system. This is usually terrific outflow, and you can have a very good fistula with this. Sometimes there are valves in here that can become stenotic, so it's useful to know that. This is what a occluded graft looks like on color. Pretty simple. And here's another example. When I talk about the whole picture here, what I'm getting at is we need to have other things that help us differentiate the high velocities that may be related to a stenosis from the high velocities that are related to a high flow but very functional and useful fistula. And the secret to that is the addition of volumetric flow as another component of the evaluation. And we don't use volumetric flow in many situations in ultrasound for a number of reasons. There's a lot of variables that can make the measurement inaccurate. However, when we look at veins and fistulas that are right under the skin, we have a lot of favorable situations. The vein is quite close to the surface, meaning that we can get accurate diameter measurements. Often, not always, the vein diameter is uniform. And usually the vein is fairly straight. So those combination of features enable us to have a better chance of having meaningful volumetric flow measurements. It is important to remember that these are qualitative values, and it's a calculated feature. Most duplex scanners today will calculate volumetric flow, not all. If you want to do it by hand, this is the equation. I would not recommend that. So technical features, how to get the most accurate volumetric flow measurements. You would like to be at least 2 centimeters from the anastomosis. Too much turbulence in the anastomotic region. You'd like a straight segment with uniform diameter and no branches, no turbulence. You want to do the diameter measurements at 90 degrees to get the most accurate ranging, and the Doppler spectra at 60. You use spatial averaging over the entire diameter of the blood vessel. And if you include a little bit of wall, usually that's not a problem, but you want to make sure that you encompass the entire flow volume. Use temporal averaging, several cardiac cycles, and it's actually good to measure in several different locations. A fistula should be a tube with the same flow at each location, unless there's a diverting branch. So multiple measurements is helpful. So here's an example of measuring volumetric flow. We've done a pretty good job with the calipers here. Volumetric flow is estimated at 726 milliliters per minute. It's not 726 millimeters per minute. It's okay. It's not low, it's not high, it's okay. So we consider this to be a qualitative number. Here's how not to do it. Here's the arteriovenous anastomosis. This is a big dilated vein. The distance that they measure here is not really perpendicular to the flow at 9 millimeters, and you get a flow volume estimate of 10 liters. Well, I don't think that's accurate. So there can be concerns about doing volumetric flow appropriately. The way to use volumetric flow is to differentiate between the stenosis that's limiting flow and the high velocities that you see in a high volumetric flow situation. And this is a nice paper from Martin Back group in South Florida. And this little grid puts, a stenosis would be, this is what they recommend for treatment, but when they talk about this, they're looking at a visible stenosis, low flow rate, they recommend intervention. If you have a high flow rate and turbulence, you may just observe that, see how the patient's doing. So putting together the volumetric flow with the findings, I think, enables you to make sense of this. So here's a case we can look at. So here's the brachial artery, the cephalic vein. Grayscale, the thing looks wide open, looks beautiful. I must not have done this one, but in any event, here's the flow in the brachial artery. Nice low resistance characteristic, 229. Here we are, I think you can see the cursors here. Here's the cursor right here at the anastomosis, 675. That's a big step up in velocities. Lots of turbulence. Look at this color mosaic. It doesn't really tell you much of anything. Volumetric flow here is 1600. Again, this is a little further down. This is a fistula that's been in place for a while, so they tried to select the base place for this. This fistula is fine. That's not a stenosis that would affect function in this case. So if we look at criteria that you can use within the conduit, people look at systolic velocity ratios of 3, visible measurement of the diameter of the conduit of less than 3, and absolute peak velocities greater than 400 probably need to be thought about. And not all of these findings indicate a significant problem. The purpose of the fistula is not to maximize flow, but to have flow that's appropriate for dialysis, which again is in that range greater than 600, probably up to 1,500 to 1,800 milliliters a minute. So, in summary, what is the role of ultrasound in hemodialysis? Well, it's critical at every stage in the maximization of autogenous access for dialysis and in the reduction of morbidity and mortality for your patients who need hemodialysis. And I think that knowing about this and utilizing it either yourself as in a diagnostic facility or as a surgeon like me in my practice, I think is the way that you're going to save the most patients. Thank you.
¿Alguna pregunta muy breve, que estamos ya con el tiempo? Sí, diga. Tenga el micrófono para que se le pueda hacer el audio.
Professor, here we don't use a lot of PTFA, we used to do the fistula, but I think it's for fear, mostly because of the cost and the fear of pseudoaneurysm and infection. I would like to know your experience about the complications, which one would be the best, or if it's not a best one.
I think there is no question that an autogenous fistula is the best. There are people who simply do not have good veins. Clever surgeons can construct fistulas using deep veins and other type approaches, but even utilizing all those tools, there will be a probably irreducible proportion of patients that will have to have a graft. And that could be anywhere from maybe 10% to 30%, depending on the population. In the United States, the construction of access for many, many years was done primarily by general surgeons rather than vascular specialists. And nothing against general surgeons. I am a general surgeon, but also a vascular surgeon. But most general surgeons prefer doing grafts because they're relatively straightforward. They don't require a lot of this surveillance and fussing and interventions, and So this is one of the things that was addressed or attempted to be addressed by that Fistula First program that I discussed. So I think some patients are going to require grafts. There's absolutely no question they have a higher rate of thrombosis, infection, degeneration, and need for replacement. You could see that in the data that I showed you, but that's a universal experience. In my practice, I still produce about 10% of my patients get grafts, just because they don't have other conduits. And the big push today in the United States is for more peritoneal dialysis, which puts a lot of burden on the patient, and not every patient has the resources at home or the support to be able to do that effectively.